Looking back over it's almost 50 years now since I joined the MRC, there have been one or two real highlights for me. I think the first of those was the study that we started in 1970 looking for a much shorter but effective treatment for TB. Up until that point in time, everybody had to be treated for at least 18 months, and it was very difficult getting patients to take their treatment. But with the advent of a new drug, rifampicin, which became available in the early 1960s, we were able to actually show that 6 months treatment was sufficient in this patient population. And this was the first of quite a large series of studies, which in fact went on to the development of TB, this particular treatment worldwide. Following the 20 years that I spent in the TB unit, in the late 1980s, I went to Uganda to work on the Uganda AIDS program, another MRC funded program. This was very interesting work because in fact at that point in time very little was known about the HIV epidemic in a developing country. Most of the research had actually been done in the Western world, and we showed very clearly that in fact what an enormous impact HIV was having on the population, even in areas where the prevalence rates were relatively low compared to some parts of Africa. And the proportion of patients who were dying from HIV compared to dying from any other cause was remarkably high. These findings were recognised as being really important in having a good understanding of what is happening to the epidemic in Africa. And it was encouraging to see in Uganda in the years that followed, in fact, a real change as the HIV infection rates dropped steadily in the years that followed. More recently, I've got back involved again in the work on TB research, and there is one area in TB which has been very badly neglected over the years, and that is in fact research in multidrug-resistant disease. For drug-sensitive disease, we have a lot of research, and there's a very solid basis for the treatments that we give. But the recommendations made by WHO, World Health Organization, with respect to multidrug-resistant disease, that's resistance to the 2 key drugs, isoniazid and rifampicin, is actually very poor, because in fact it's based not on clinical trials but really on expert opinion and a limited number of cohort studies. Currently I'm involved, indeed I'm Chief Investigator of a study which is looking at a new regimen which hopefully will be much more acceptable to patients and more effective than the current recommended treatment, which goes on for almost 2 years. Whereas this treatment is for just 9 months. Recently that study has also been expanded to bring in a new drug, a totally new drug, first new drug for TB for just about 50 years since rifampicin, and which should enable us not only to give a more effective treatment, but a safer treatment one, because we're hoping to be able to drop the injectable, which actually causes a lot of problems for many patients.